Our last topic is on menopause and Parkinson's disease. And in a survey that we recently conducted, this survey of EAN members, and again, thank you for everybody who participated, 40% of European neurologists stated that they think that female hormonal factors do not impact Parkinson's disease at all, or if they do, then only very slightly. And I would like to use this opportunity to prove those people wrong. Yes, so in the next 20 minutes, I would like to talk with you about several points. So first of all, menopause and Parkinson, do we need to talk about this? Is this relevant? Then we already heard about the role of estrogen in migraine, in cardiovascular diseases, and does it also have a role in Parkinson's? Then is there any link between menopause, different types of menopause, and risk of Parkinson's disease? In Parkinson's disease itself, are there any specific features that we need to be aware of in our women patients? And then at the end, again, which role may hormonal therapy play for women with Parkinson's disease? So to start, is it actually important? Well, this question is quite easy to answer. Yes, it is really important to think about links between menopause and Parkinson's disease. And this is because we know Parkinson is a disease that is very fast growing in its prevalence. It is the fastest growing neurodegenerative disease. And based on the global burden of disease data, we expect that 2050 there will be 25 million people worldwide living with Parkinson's disease. And for the same reason, because we as population are aging, we women spend more and more time in a postmenopausal phase. So at the moment, an average woman in Europe spends 40% of their life in postmenopause. And women, as we know, make up 51% of the world's population. So taken together, we have a disease that is frequent and is even becoming more and more prevalent, and we have this long period of our lives. So it's important to understand how the two interact. And why do we think that they might interact? Well, we have many signals to think this. We know from the epidemiological studies that Parkinson is more prevalent in men than in women. We know that the age of onset of Parkinson's disease is later in women than in men. Once the Parkinson develops, then also it is typically different in men compared to women. So, for example, in terms of motor symptoms, women tend to present with tremor more frequently, whereas male patients usually present with more bradykinesia, hypomimia, speech issues, so also more axial symptoms. Non-motor symptoms differ between the sexes as well. So women have more pain, experience more anxiety and depression, whereas men tend to progress faster into a cognitive decline. From the neuroimaging studies, we also have some evidence that the neurodegeneration rates are greater and faster in men, and also we women metabolize levodopa, which is the main pillar of Parkinson's treatment, differently. So we do have higher concentration of levodopa in plasma. So all in all, it seems that there seems to be some protective factors in us women against Parkinson's disease. And likely there are several, because there are many biological differences between male and female individuals, not only hormonal, but also, for example, genetic. However, estrogen here seems to have an important role. And we have already heard that estrogen is really a brain hormone, we can say. It's a neuroactive steroid, and it does influence the dopaminergic neurotransmission in our brain. So we do know from preclinical models, we do know from the studies in animals that estrogen enhances synthesis and release of dopamine, while at the same time reducing its reuptake and breakdown, and also modulates the dopamine receptor sensitivity. And that's why during our reproductive phase, our dopamine in our striatum actually fluctuates in accordance with the fluctuations in estrogen levels in plasma. So it seems to really, it seems that estrogen really plays an important role in dopaminergic neurotransmission. And it seems that we women are, our bodies and our brains are used to it, and we notice it when we lose this factor. So several studies have signaled that women with Parkinson have a shorter reproductive lifespan, meaning a shorter exposure to the natural endogenous estrogen than women who don't have Parkinson. And this association seems to be even more pronounced when this estrogen drop happens abruptly, which is the case after a bilateral oophorectomy or hysterectomy, for example. This is a recently published meta-analysis that has shown that women with bilateral oophorectomy have a heightened risk of Parkinson's disease. And I think this is really a nice opportunity, because for Parkinson we now have more and more potentially disease-modifying trials, which all need to be started as early in the disease as possible. So if we are aware of vulnerability of this population, maybe we all together can be more sensibilized, and maybe we have a chance to recognize Parkinson's disease earlier in these women and offer them possibly participation in disease-modifying trials. But this is in the future. We are not that far yet. Yes, so when Parkinson's disease develops already, there are also certain aspects that differ, aspects of care that differ for our men and women patients. And this is one very nice overview by Professor Powe that shows different phases of Parkinson's disease. And on this picture of Professor Powe, I added these small ladies on all phases of Parkinson's disease where it is relevant to consider sex and gender factors. And you can see that basically throughout Parkinson's disease, it is actually important which sex and gender is our patient. And it starts already in the prodromal phase. So prodromal phase of Parkinson's disease is a phase before the matter symptoms occur. And people present with a range of different non-matter issues that are quite unspecific. So they might present with some memory issues, with some emotional distress, or constipation, or increased tiredness, or maybe disturbed sleep. And those might might sound familiar to you because those symptoms are very similar to symptoms of peri or menopause. And that causes a problem that in women it may be hard to recognize that these symptoms are beyond menopause, that those are caused by a neurological disease. And in many cases, it's not rare that this leads to a delayed diagnosis of Parkinson's disease in women. And this is an interesting study that has shown that women actually seeked medical attention with the same delay after their first symptoms started. But for women, it took much longer to get referred to movement disorder specialists than for men, because those symptoms were in many cases not recognized. Then once Parkinson's disease started, motor symptoms are present, and we are in a dialogue with our patients, which therapy should we start. And as it is usual in medicine, we have several options. None of those is perfect. Each one has pluses and minuses that we need to discuss with our patients and take this decision together. Also here, sex and gender are very relevant. Because among the options that we have, for example, the number one choice is levodopa, which is the most effective treatment for Parkinson's disease and has the greatest effect on the motor symptoms. However, in a long term, levodopa is associated with occurrence of motor fluctuations and levodopa-induced dyskinesia. And these are much more frequent in women than in men. On the other hand, the other alternative option, dopamine agonists, may be associated with different neuropsychiatric features, among those impulse control disorder, and men have a significantly higher risk of those problems than we women. So also in this conversation, when starting the first therapy, we need to bring in those sex and gender aspects. And then as the Parkinson progresses, people start experiencing those already mentioned motor fluctuations, which express themselves as different effect of the medication and loss of the medication effect between the doses, as well as levodopa-induced dyskinesia, which are involuntary movements. And I think this is, in my opinion, the most important study in Parkinson's disease, in gender factors in Parkinson's disease. This is a recently published observational study that has followed people with Parkinson from the diagnosis throughout starting levodopa and then for 2 years. And in those 2 years, you can see here the comparison. So in terms of the motor fluctuations, 50% of men developed motor fluctuations during these 2 years, but 65% of women. And for the dyskinesia, it was even more obvious, this difference. So 2 years after starting levodopa, 5% of men, but 15% of women had levodopa-induced dyskinesia, so 3 times that much. And then, however, we do have treatments that we can offer to people who have motor complications and levodopa-induced dyskinesia. So we offer those people device-aided therapies, which can again bring a balance, which can shorten this period of either fluctuations or dyskinesia. And now you would think that women, because they fluctuate more, they get more more of those treatments. But actually the opposite is true. So we know for the deep brain stimulation that women actually get disproportionately less referrals and less surgeries, although when they undergo the DBS surgery, they have same benefit as men do. We don't have any data for the pump therapies yet, but we know here from the analysis from Kasia Smilovska and Vanessa Carvalho and others that these female-related features are not that considered in trials for pump therapies, because either women participate less, or when they do, the reproductive history is usually not recorded. And then we came to the advanced Parkinson's disease, to the late stage of Parkinson's disease, where the disease changes and axial symptoms, gait issues, and falls become the most severe problem. And also here, women seem to be more vulnerable, because you know that osteoporosis is more frequent in women than in men. In people with Parkinson, it seems this difference seems to be even more pronounced. So women with Parkinson really have a very high risk of osteoporosis. And this has consequences, because if you combine osteoporosis with falls, it can lead to fractures that then restrict mobility and lead to worse outcomes. And this is exactly what has recently been shown now in the PPMI Parkinson Progression Markers Initiative analysis, that women with Parkinson have more fall-related injuries and more fall-related hospitalization than male patients. And then finally, since estrogen seems to have so important role in Parkinson's disease, naturally there comes a question: can we then give women with Parkinson a substitution? Will that be helpful? And the answer is that we do not know. And I think today you heard so many we don't knows, because it's actually surprisingly little research being done in the role of hormones for neurological health. And this is an example. You can see here we have here in the EIN we have just conducted a systematic review on the role of hormonal therapies for postmenopausal women with Parkinson. And overall we found only 5 studies that have investigated these questions. And you can see from their date that they are quite old, some even from the 90s. And then they used the different preparations from those that we use today. So we really cannot take those results for our clinical practice. And the studies were also small and were methodologically not that robust. So the answer is that we really don't know, and it's a huge knowledge gap that we really need to investigate, because it can be a good opportunity to improve the management of Parkinson's disease in women. With that, so if you are interested in the topics that we talked about today, I would like to invite you to join the Insight Network. So since 2024, the American Academy of Neurology has a women's neurology curriculum which seeks to answer all these questions. And the Women's Neurology Insight Network is a US-based online network from neurologists who are working towards the improvement of neurological care for women. And you can look at different offers here. There are always series of free webinars, really nice educational opportunities. And with that, I would like to thank all of you. I hope now people would answer this question about from our survey differently. That not 40% of people would say hormones are not related to Parkinson. We now know they are, pretty much so. And with that, I would like to thank the team here at the EAN that is working really hard to address those issues and to improve our knowledge. And I would now like to hear from you, your thoughts or questions or comments.
Yes, I have a question regarding the DBS in women, because I heard previously that the reason that women are undergo DBS less frequently is that it is often a wake surgery and that women are more hesitant towards that ID. Is it also something you heard, or are there other relevant factors why they don't get DBS?
Yes, thank you very much. That's an important question. Again, I have to give you one I don't know.